Hello everyone, in this video we will discuss about the Paroxysmal Nocturnal Hemoglobinuria or PNH. So by definition, this is an acquired clonal hematopoietic stem cell disorder characterized by a triad of intravascular hemolysis, venous thrombosis and the bone marrow failure. This is the only hemolytic anemia caused by an acquired genetic defect. Only hemolytic anemia caused by an acquired genetic defect. Now we'll see the pathophysiology of PNH. Gene mutation seen in PNH is a somatic mutation in PIGA, stands for the phosphatidylinositol glycan class A gene. So PIGA gene is mutated in PNH. This gene is present on the X chromosome. As we have already said, this is an acquired genetic disorder, not an inherited genetic disorder. So PIGA gene is essential for the synthesis of GPI-anchors, glycosyl phosphatidylinositol anchors. So deficiency of these GPI anchor will result into the loss of GPI linked surface protein. So this is PNH is a disorder of hematopoietic stem cells. That's why it affects all the cell lineages, RBC, WBC and platelets. So what are the GPI linked proteins? In PNH, the loss of these specific complement regulatory protein is critical, known as, the first is CD55, also known as decay accelerating factor. Normally this inhibits C3 and C5 convertases. CD59, also known as membrane inhibitors of reactive lysis. This is the most important GPI linked protein involved in the pathophysiology of PNH. This prevents the formation of membrane attack complex. And the third GPI linked protein which is deficient is C8 winding proteins. So due to their deficiency, there will be an abnormal activation of the complement and there will be hemolysis. So this is the flow chart of PNH pathophysiology. As we have discussed, this is an acquired somatic mutation in hematopoietic stem cell in the PIGA gene, and this will result into the defective GPI anchor proteins and ultimately absence of the GPI anchored proteins on the blood cells. GPI deficient red blood cells, they have low or absent CD55 or CD59. Normally CD55 is inhibit the C3 convertase and C5 convertase and prevent the activation of the complement system. CD59 normally this inhibit the formation of the membrane attack complex. Whenever this CD59 is deficient in PNH, there will be an excessive activation of the membrane attack complex, and this causes the hole in RBC and result into intravascular hemolysis. As we have discussed, due to the decreased GPI anchored protein CD55 and CD59, there will be uncontrolled complement activation. This will result into the chronic hemolysis. This can be intravascular, while membrane attack complex mediated, or the extravascular due to the lack of inhibition of the C3 convertase. As C3b act as opsonization, and this will result into the increased phagocytosis of red cell by the macrophages of spleen and liver. So in intravascular hemolysis, there is direct lysis of the RBC due to activation of the MAC, and hemoglobin released into the blood stream result into the hemoglobinuria or hemosideриnuria. This free hemoglobin bind nitric oxide and ultimately result into the decreasing nitric oxide level. Due to low nitric oxide level, there will be smooth muscle dystonia in the form of esophageal spasm and erectile dysfunction, and the elevated level of LDH and bilirubin, low hepatoglobin are also seen in the intravascular hemolysis. So these are the we have discussed about the hemolysis and anemia. Now, due to uncontrolled complement activation, there will be thrombophilia or venous thrombosis. As we have discussed, the free hemoglobin binds with the nitric oxide and result into the decreased level of nitric oxide. So there will be more platelet aggregation, and there is increased chances of the formation of the thrombus. The common sites for the thrombosis is hepatic vein, Budd-Chiari syndrome, portal vein, mesenteric vein, and cerebral vein. Due to uncontrolled complement activation, as we have discussed, this PNH is a disorder of hematopoietic stem cell. There can be a marrow failure, hematopoietic stem cell dysfunction, or increased apoptosis, ultimately result into the pancytopenia, decrease in the RBC, WBC, and the platelet count. Treatment option for the PNH is C5 inhibitors like eculizumab, ravulizumab. They block the MAC formation and decrease the intravascular hemolysis. Another group is proximal C3 inhibitors, pegcetacoplan. This inhibits C3 convertase and C3V opsonization. So this will help into the controlling both intravascular and extravascular hemolysis. So this is the diagrammatic representation of the paroxysmal PNH pathophysiology. Now we'll see the clinical feature of the PNH. Features of anemia, particularly hemolysis, which is chronic intravascular hemolysis, and only the 25% of the cases have nocturnal paroxysm. Mechanism behind the nocturnal hemoglobinuria is in the night there will be slight decrease in the pH. pH is slightly decreased in the night, and this will result into the activation of complement system, and so there will be hemolysis. Thrombosis is the leading cause of death in PNH, and the common sites are hepatic, portal vein, and cerebral vein. Bone marrow failure is frequently associated with the aplastic anemia, and on the long run 5 to 10% cases of PNH may develop into the AML or myelodysplastic syndrome. This also suggests that the pathogenesis is somewhere into the hematopoietic stem cell. So ultimately they result into the AML and myelodysplastic syndrome. How to diagnose PNH or paroxysmal nocturnal hemoglobinuria? Gold standard for diagnosis is flow cytometry. They detect the absence of CD 55 and 59 on the RBC or granulocyte. The most sensitive test is fluorescent proaerolysine that bind directly to the GPI anchors. Classically, there are some tests like Hames test, acidified serum test, and sucrose hemolysis test, now mostly replaced by the flow cytometry. And other biochemistry or clinical biochemistry finding, they involved in the urine. There is increased hemosideриnuria, or there will be hemosideриnuria, ultimately leading to the iron deficiency, and there is decreased heptoglobin level and increased LDH level in the serum. So as we can see, there is in the PNH CD59 is deficient. This is the flow cytometry image of the this is the image of RBC showing CD59 deficient population. The neutrophil CD in flare. This is the deficient population. So how to manage or treat a case of PNH? Targeted therapy like eculizumab is a monoclonal antibody that work against the C5 and prevent the conversion of C5 to C5a and C5e, and ultimately block the formation of membrane attack complex. This reduces the hemolysis and the thrombosis risk by the 90%. So eculizumab is a very important drug, but this increases the chance of meningococcal infection. So the vaccination is mandatory before starting the treatment with eculizumab. And as we have discussed, due to chronic hemolysis there can be iron deficiency, anemia. So in supportive therapy we provide iron and folate supplementation. Hematopoietic stem cell transplant is the curative option of management. Now high yield points for the NEET PG exam. The mutated gene in PNH is PIGA gene, which is X-linked, and this is an only acquired genetic hemolytic disorder. Most important protein is CD59, also known as membrane inhibitor of reactive lysis. Screening test is flow cytometry, or most sensitive or best test is flare. Cause of death is venous thrombosis. Flare is also flow cytometry. Drug of choice is eculizumab. Association of PNH is with the aplastic anemia because of the bone marrow failure, and long run may convert into the AML or MDS, and urine findings are the hemosideриnuria may result into the chronic iron deficiency. Thank you for watching the video. Thank you.